السلام عليكم ورحمة الله وبركاته. أهلا بكم أيها الزملاء الأفاضل في هذا اللقاء المتجدد كجزء من النشاط العلمي لوحدة جراحة الجهاز الهضمي والكبد بمستشفى العبور بكفر الشيخ. وحدة جراحة الجهاز الهضمي والكبد بمستشفى العبور وحدة منشأة جديدة بتشمل 3 سب جروبس: وحدة هيباتوبيلاري، وحدة كولوريكتال، وحدة ادفانسد لابروسكوبيك جي سيرجري. إن شاء الله النهاردة بنبدأ مجموعة جديدة من الويبينارز على الكولوريكتال سيرجري، ونتشرف إن يكون معنا النهاردة أستاذ الدكتور ماجد عاشور بسيوني، the Professor of Colorectal Surgery and Laparoscopic Surgery in United Kingdom. هيبدأ الطريق في مجموعة ويبينارز on Colorectal Cancer والعنوان to be early and on the optimal route to cure. بفكر حضراتكم ان احنا زي ما اتفقنا هيبقى احنا مراجعة مؤشر الصوت ومراجعة الفيديوهات، كتابة الأسئلة. فكر حضراتكم ان احنا الويبينارز ديت عبارة عن مجموعة من الويبينارز بدايتها الدكتور ماجد بسيوني. بعد كده في عندنا ان شاء الله الحد الجمعة 7/1 مانجمنت اوف كولونيك جلوبوزس دكتور وليد الشاذلي استاذ جراحة الشرج والقولون جامعة الاسكندرية. بعدين الدكتور صفوت عبد القادر استاذ جراحة العامة وجامعة القاهرة هيرنيا مانجمنت، واستاذ الدكتور خالد مدبولي الجمعة 21/8 مانجمنت اوف كرونيك كونستيبيشن. وبعديه هيبقى الاربع 26/8 هيبقى بانل انترناشونال بانل، هيبقى المودريتور فيه الدكتور ماجد بسيوني MTD about a case of colorectal cancer. في النهاية يعني بنقدم الشكر الكبير والعميق للأستاذ الدكتور ماجد بسيوني ولحضراتكم زملاء الأفاضل الكرام تشريفكم لينا، وبنتوجه بتهنئتنا لشعبنا والأمة العربية جمعاء بعيد الأضحى مبارك إن شاء الله، نسأل الله أن يعيد علينا وعلى أمتنا بالخير والبركات. تقبل الله منا ومنكم صالح الأعمال وكل عام وأنتم بخير. وأسيبكم مع الدكتور ماجد بسيوني عشان نبدأ إن شاء الله محاضرتنا.
أنتم بخير. أتمنى تكونوا سامعيني كويس. Please use the chat option if you want to send anything soon, and I'm sure Dr. Ahmed Saadi, inshallah, will help running this very smoothly and to the best interest and best benefit of everyone. Let me just check that controls are perfectly run. No, yeah, everything is okay. Well, it is really my pleasure to join you today for this webinar, which is in a very successful program run by Dr. Ahmed Saadi and the Obour Gastrointestinal and Liver Disease Unit, which is really a massive, massive initiative, and I congratulate him and everyone taking part in it. What I will talk about today is part of a workshop that runs over 3 days, talking about colorectal cancer only, and actually mainly about rectal cancer, because it's very misunderstood. Most part of the world is misdiagnosed and mismanaged. While it forms 27% of colorectal cancer, it's beyond me. It's so accessible, it is so easy to detect early, but it's always missed and it's always diagnosed late, and it affects people's lives. Even if they survive, the effect on the quality of life is immense. This program usually runs in 2 parts. We talk about the anatomy and physiology, the epidemiology and pathology, clinical presentation and diagnosis. And then we take coffee break or another day, and then we talk about the staging and the treatment, which usually take part in a form of MDT. What we usually try to do, we talk about the staging by the people who will stage the tumor, not only the surgeons, but gastroenterologists, because they are very clever, radiologists, and then the surgeon takes part, and we talk about the treatment with the oncologist present, gastroenterologists, because they can treat early cancer, and we talk about the outcome and how the MDT runs. Today, we'll stop at the diagnosis, and then hopefully in the next webinar, we will talk about the second part of the workshop. What I want to say today that I will talk not quickly, but not in details, broadly, because it's extremely important to understand. For the last 30 years or so, although I've been visiting Egypt a lot, very regularly, but I practice in a different world, in a parallel world, which make me more or less not part of the Egyptian system. So what is very important in this webinar, because it's targeted to Egyptian surgeons and young surgeons, which I hope they are present in abundance, that it's your platform, not mine, or the speaker, or Dr. Ahmed Sadi. So I need participation. Hence, I will leave a lot of time in the end for questions and answers. And hopefully, inshallah, everyone will benefit. I don't want to remind you of everything about the anatomy. I'm sure that you are aware. But what I want to focus on, something extremely important. A colorectal surgeon is nothing but an abdominal vascular surgeon, bar the aorta. You need to understand very well the blood supply, arterial, venous, and the lymphatic drainage of the colorectum to understand why we do what we do. Everything has changed in the last 20 years, and that is why the outcome of treating colorectal cancer has improved and the survival has improved because of our understanding of anatomy and because of our understanding of lymphatics and the vascular supply. The complication rates will improve if we understand it. One point I will point to here in this diagram is something called the arc of Raylan. This is surprisingly present in 15% of people. And in its presence, usually this arcade here, and if you know this is the danger point of Griffith, is absent. And this is the main blood supply of the left colon and the distal part of the transverse colon. You will not see it except if you think about it while you are dissecting and resecting this part of the colon. It will very much look at like the ascending left colic artery, but a little bit closer to the origin. However, you can't really know if the left ascending colon doesn't exist. You wouldn't know if this is the left colic or not. So preserving anything close to the origin and the benefit of high tie is really highlighted here because of the 15% of people who will have the arc of Raylan. The arc of Raylan's presence will show itself to you postoperatively, usually in day 3, when the left colon, which is left to be diagnosed to the rectum or the anal canal, is dead and the patient is nearly dead. It always means that you have tied this artery. The venous supply is important, maybe not for oncological reasons, but for ease of mobilization, especially of the left colon, that splenic flexure. But also it has become extremely important recently to understand the anatomy around the superior mesenteric vein to achieve what we now apply in cancer of the right colon and the cecum and the terminal ileum, for that matter, of the complete mesocolic excision. This is something that we'll talk about in the treatment options of colorectal cancer in the next webinar or two, but the venous supply here is very important. Some of the veins are consistent, most of them are not, and detailed anatomy here is extremely important. But what you need to, the paradigm shifts that I'm trying to deliver today is we always focus on this arcade of veins and arteries, and we know that lymphatics all stop here, for example, at the base of the mesentery, if we wanted traditionally to achieve a radical resection of the right colon. But what we have found that the right hemicolectomy leads to high rate of recurrence, either metastatic or local, due to the presence of lymph nodes here on the other side of the SMV. Hence, the dissection now is focused on coming to the other side of the SMV, which is called the central venous ligation or central vascular ligation, together with complete mesocolic excision. Understanding where the rectum ends and when the sigmoid colon starts, how long is the rectum and the anatomy of the rectum from the inside and also from the outside helps you decide on the need of the preoperative adjuvant and neoadjuvant chemoradiotherapy or the postoperative radiotherapy, adjuvant radiotherapy. So understanding is very important. The variance here between 15 and 17 centimeter is between America on the 17 centimeter limit and the rest of the world. We all agree that the rectum is only 15 centimeter. And also where the anal canal starts and where the rectum starts in conjunction with the anal canal is variable, but it is very important to understand two aspects when you look at the patient clinically: the elements of prolapse, which is usually present in elderly people, especially women, and also where to measure the distance from the anal canal. Always try to use the dentate line or pectinate line. The measurement from the anal verge, as we usually say in our reports, is not very accurate because that is not a fixed feature. It varies in distance with the degree of perineal descent, especially in women who have given birth 3 or 4 times, and their perineum is not supporting the anal verge, but the landmark here is very much related to the blood supply, which is more important than this part of the anal canal. Okay, so that's the levels of the rectum. Again, the lymphatics, especially of the rectum, are extremely important to understand. And what we need to really understand is these vessels. And these lymph nodes now have become more important, not only in Japan as they used to be, but all around the world. And there is a great debate going on now in the colorectal communities about pelvic lateral dissection, lateral wall dissection, routine, selective, or not at all. And this is not the subject of today, but we will talk about it when we come to the treatment of rectal cancer. The nerve supply and the nerve's relation to the rectum are very important. And that is what we have to focus on. When I talk to my patients and my students, I always tell them, we do not prolong anybody's life. We do not cure, we operate. We get rid of what we see of cancer. But what we can do, bi'idhnillah, is to improve people's lives by giving them the best option of living pain-free, cancer-free. But what we are not good at is looking at the function after surgery. And usually we cause harm by destroying these little things in the pelvis. In the West and in the UK where I work and practice, that has been sorted by centralization. Cancer rectum has now become the only colorectal operation that has to be centralized. In every region, 2 or 3 or sometimes 1 surgeon will take over all rectal surgery. Any tumor below 12 centimeter or 15 centimeter in some regions will be responsible for rectal cancer. Not every surgeon does it. It needs a lot more extra training, a lot of more equipment, nurse care, joint MDT with the urologists and sometimes vascular surgeons and sometimes gynecologists, and pelvic excenteration has become part of treatment of either primary rectal cancer or secondary tumors or even recurrence. So I don't know if that can be applied in Egypt or not. It's very different practice and it's very different atmosphere. But I am here to tell you how the rectal cancer surgery improved over the last 25 years or so by centralization. So what's happening? How often does the colorectal cancer happen? How common is it? I'll tell you my own experience, to be honest, before the statistics that's published. I've been visiting Egypt for the last 20 years, since 2001, after I disappeared for probably 15 years or so. And every time I visit Egypt 3 times a year, and every time I visit between 10 days and 2 weeks. Before I left Egypt many, many years ago, I didn't see colorectal cancer, let alone see it in the young people. Now, there isn't a single visit I go to Egypt and I do not see 2 or 3. And I only see a very small proportion of patients, obviously, but 2 or 3 people, teenagers, and 2 or 3 people aged less than 30 years old. This is uncommon. This is very rare all over the world. We tried to look into this. We couldn't get statistics right because there is no registry in Egypt. The service is fragmented and diluted between too many service providers, we call them. Private sector taking large chunk with no registration of any sort. And the government sector is very poor in providing, and really must say that. And it is just too many authorities. So to get the data right in Egypt is very, unfortunately, not very conducive, as we call it. So the WHO does have some data, but I am not sure of its accuracy. I don't know, you'll ask yourself if there are 32 participants now, and whoever will watch that can just ask themselves honestly, how many times have they registered their patients they found in their practice at WHO website, or any database for that matter? Colorectal cancer is the 10th most common cancer in humans, either in men or women. The prevalence is slightly more in women, however, the numbers are higher in men, just because there are so many men with cancer in the world more than women. But the breast cancer topples that, so we have to be careful. The equivalent of breast cancer in men is prostate cancer. Fortunately, the lung and bronchus have increased. These data are from 2016. This data is slightly different in number, but the same ranking, and is present at 2020. The distribution around the world of the incidence of colorectal cancer, as you see here in the Western world, in America and Europe, is extremely high, more than 32.2 in 100,000, which means it's 1 in 50 people who will walk in the streets will have colorectal cancer at some stage of their life. It's luckily, alhamdulillah, is a lot less, but still 5.4 to 9%. If you look at this data here, 5.4 to 9%, it's a very wide range. And the width of that range means, unfortunately, inaccuracy of data. But let's imagine it's 8 per 100,000. It means that there are now, as we speak, there are 800,000 people with colorectal cancer walking the streets of Egypt, of all ages. Can you imagine this, the magnitude of the problem in Egypt? It is equal to England, who has 66 million, probably exactly the same number. And the service provision is different, very different. We don't know very much about the mortality rate from colorectal cancer in Egypt because this data in the WHO data is not accurate. They say it's not complete. Where does it arise from? For the young people among the audience, I'm sure the senior people will know that very well. But as I mentioned, if you just look at the colon to here, to the top of the sigmoid colon, meaning that you can reach more than half of colorectal cancer by looking in the clinic by radiosigmoidoscope to here or to here, and you will see the blood coming from here through your nose. You can reach by a flexible sigmoidoscope without preparation except an enema and without a lot of cost. And in the office, without anesthetic, without anything at all, during the initial examination, you can reach up to the splenic flexure, and that will give you 78% of bowel cancer discovered in the first visit. I don't know if that practice is practical in Egypt or not, but it must be to detect early cancer, to detect precancerous conditions. If we put a slide of the distribution of colonic polyps, it will be exactly the same. So detect a polyp and remove it, it's cure, isn't it? It's prevention. So maybe we need to think carefully of what practice we do, and we will come back to that later. Now, quickly, what are the histological types of colorectal cancer? We don't want to spend a lot of time on this, but 90 to 95% of it is adenocarcinoma. Carcinoma tumors constitutes less than 2%. Gastrointestinal stromal tumor, which arise from very special cells called cells of Kagel. They are rare in the colon, but common in the small bowel and the stomach. Duodenum also is a commonish site. Lymphomas are rare. Sarcomas can happen. I've seen in my life 38 years of treating colon cancer. I've seen it twice. Secondary tumors, I haven't seen any. So I don't know how often they are, but they are recorded. Leukemia, I've seen 3 cases in my own experience. They're only, if we talk about numbers, they're only published cases. There isn't any series of any description. How does it spread? It spreads through the wall, and we all know that T0, where there's no cancer, to T4, where the cancer invaded surrounding structures. And in the colon, these surrounding structures are anatomical structures, not the mesentery. And the anatomical structures is the duodenum, vessel, the ureter, the stomach, the greater omentum, which is a separate organ. So we have to be very careful with our definitions. Transperitoneal spread really happens in rare forms of cancer, which is the myxomatous cancer, and causes carcinomatosis peritonei, which is something very highly specialized in its treatment in only a handful of centers around the world. And it's rare, and the chance of cure is also not that great. Implantation is the most common practice, is the common incidence of spread in the Middle East, in my opinion, because everyone who has bleeding per rectum is easily diagnosed with hemorrhoids, and they go straight to hemorrhoidectomy without previous investigation. And let's be honest, this is a very, very common practice. If someone sees a fistula or a fissure, regardless of age, and I'm talking here about people above the age of 40 in the Middle East, they are subjected to operations which can lead to implantation in the site of the operation in the anal canal, which is a spread, but iatrogenic spread, not natural. And again, you all know what it's like, and we can argue until the cows come home, but it is very common practice. Sometimes I see patients that never had a PR examination before they were subjected to hemorrhoidectomy, fistula, or fissure operation. Lymphatic spread is very known, and it's usually antegrade upwards, and it depends on where the cancer is. The venous spread doesn't happen spontaneously. It usually happens during the first 3 minutes of anesthetic. This is something extremely common because and also very detrimental. Many patients do not like to come to surgery because they know if the tumor is small and you are operating on me, I will get metastasis anyway. I don't want surgery. I will go for chemotherapy and radiotherapy. There's no answer to that, because what actually happens is not the surgery that gives them the distant metastasis later or terrible life. It's actually the anesthetic, and there is a lot of literature to support that. I didn't want to bore you with reference today, but I can put them up on the website at some stage when we finish the whole series. Liver and lungs are commonest sites of colorectal cancer spread by venous spread, but it's not common to bypass the lymphatics, meaning that lymph node involvement always appear before the liver, and the liver almost always before the lung gets metastasis. There are skip lesions, and it can skip by venous spread. However, it is rare, not like melanoma or breast cancer. What are the risk factors and why we're talking about it today with diagnosis? But to know that what happens in the society, we know what questions to ask and what signs, extra colonic, extra-intestinal signs we look for. So always put in your mind and ask your physician and general practitioners and all doctors who practice in small mustashafat or at home or they become specialists at the age of 24. Just teach them around you so they teach the community and they be able to pick up patients who can be saved. Not only their life, but also the quality of life can be saved. So these risk factors are important. They are not in theory. They are not to just answer questions in exams and pass fellowships. They are very important in real life, okay? So we'll spend some time talking about it. Diet. Leave alone alcohol, although I understand that drinkies now are everywhere, and I've seen them in places in Cairo. I couldn't have ever thought of finding alcohol in these places. Extremely poor areas with 3 or 4 shops in the space of 100 meters. So I cannot exclude huge alcohol consumption in Egypt, as I did when I was in Egypt in the 80s. It does happen, and you have to take it into consideration, and you have to ask. You have to see the signs, the telltales of alcohol consumption. Ask young people, because it's very important, and they do drink heavily when they drink in secret. So that's something very important. There isn't a single house in Egypt that doesn't consume processed meat. Luncheon, pastrami, pasterma, sausage, sago, hot dogs, McDonald's, all fast food is processed. Not only the meat is processed, the chips, the fried potatoes, these are processed foods in highly carcinogenic environments. And what we do not know, or many of the public don't know, and I hope that you do know and pass this information to the public, is the barbecue and the char-grilled meat. When it reaches the beautiful crusts of black on top of the meat, it's carcinogenic. It should not reach that color. And consumption of large amount of this, and the hayati, and when you go to anywhere in Egypt to find, especially in cheap places, queues of people are consuming kofta, which is burnt. And the reason it's burned because it tastes better as it's processed in the volatile components of spices and shatta. And in essence, it hides what the meat is really like. But in fact, scientific fact, it gives people cancer. What is the protective food and high fiber, fruits and vegetable? Things have changed dramatically in Egypt, diet-wise, and people don't eat fruits and vegetables now very often as they used to do when I was young. That is why we see more of bowel cancer. It's not the Western diet, and it's not conspiracy. Israel is not putting the cancer in Egypt, but it is our unfortunate dietary habits. Added to this, how many of us exercise regularly, definitely better than the past. Lots of people exercise now, but it has to be regular. We like watching television and sitting, and we unfortunately have very high rate of obesity, and we are all successful in bariatric surgery and becoming very competitive because of the obesity. Problem is, bariatric surgery now is proved to increase the incidence of bowel cancer. And so unfortunately, the obesity does have a major factor, and gastric bypass also does have another contributory factor to colorectal cancer. It's very complex. Smoking, oh my God. Where in Egypt you don't see smokers? Where in Egypt there are no smoking? Young people more than others. And all forms of smoking, shisha is worse than smoking cigarettes. And it does have a major factor in increasing colorectal cancer. So someone who's smoking coming to you with bowel with bleeding, do not say it is hemorrhoids. Please investigate them first. Okay, alcohol we spoke about. Age, it's above the age of 50. In the Middle East, there is a screening program in the United Arab Emirates, and I was honored to be part of establishing it, and I know it is above the age of 40, not 50 in the Middle East, due to genetic factors and due to the change of diet that's happened over the last 40 years. Any history of polyps or previous colorectal cancer is a risk factor. So all that needs to be asked, not only in the patient themselves, but also in the family. The details of the polyps are very important. Don't take it from the patient that I had polyp removed. Look at the reports of these polyps that were removed. Find out if there are multiple polyps, the size of them, type of them, like adenomatous polyps. Only 10 years ago, we didn't consider serrated adenomas as precancerous. Now we understand better the genetics, and we know about the MIS, we know about KRAS, we know about MUHC, that serrated adenomas are very strongly related to these genes, and they are precancerous. Inflammatory bowel disease, if it stayed more than 10 years, the risk is only 5%, but 20 years is 10%. One good thing about Egypt that IBD is not common. However, I think it is hidden. It's not diagnosed enough. But there is a trend recently, in the last 4 or 5 years I've seen Egypt without statistics, that people are told that they have ulcerative colitis a lot more than before. When I look deeply, and every patient will come to me for a second opinion, they don't usually have ulcerative colitis. It's usually infective, and it's usually water-related infection. But, or something we call eosinophilic colitis. It's very, very common in Egypt. But it's very rarely diagnosed, and people are told that they have ulcerative colitis. I don't know how to sort this problem out, to be honest. There is a lot of work need to be done. If with the IBD there is dysplasia-associated lesion, this view has been around since the 70s. It is cancer until proved otherwise, and patients should have resection, but our gastroenterologists, bless them, they always try to keep these patients on medical treatment. These lesions mean surgery for IBD. General risk, I said it's 1 in 50 in the population. We don't really know the statistics in Egypt. However, this is the answer you will need to give in any international exam. If there is one first-degree relative older than 45, the risk is doubled to 125. If there are 2 or more, first degree relative is 1 in 12. If there is genetic syndrome like familial adenosis polypi, it is 100% risk of cancer. This is Bethesda criteria, and there are now the version 4 and Amsterdam criteria, which is not very different. So in the exam, just remember these figures and also remember where they come from. Bethesda is your help. What are the genetic syndromes that lead to cancer? Is familial adenosis polypi, mutation of the APC gene, and it has 100% risk of cancer. Gardner syndrome is extremely rare, but it is a type of FAP, but benign, non-cancerous tumors of skin, soft tissue, and bones. NPCC has a major role in colorectal cancer because it's 2 to 4% of cases, double the incidence of FAP. And it's now we know what genes are affected, MLH1 and MLH2, and they have very important clinical implication. HNPCC usually happen on the right side. There are no associated polyposis, and it runs in families. So it's diagnosed earlier in life, but always later in stage. However, if we know the family needs to be screened, okay? But there is risk of endometrial and ovarian cancer with it. So when you ask the family history, do not only ask about bowel cancer, do not forget endometrium, ovary, ureteric and urological cancer, pancreatic, and less so of a gastric cancer, okay? Familial adenosis polypi doesn't have to look like this in the specimen. In endoscopy, it looks like that. And for someone who hasn't seen that before, you need to, if you suspect FAP, and without even family history, mutations are not uncommon. It does happen for the first time in the family. Refer the patient for fundoscopy. This lesion is very important, hypertrophic pigment, and it's very characteristic of FAP. So even before you do colonoscopy to find these, or if the patient is genotype but not phenotype, they will always have this lesion. There are other syndromes like Turcotte syndrome, and less uncommon, I wouldn't say it's very common, Peutz-Jeghers syndrome. And again, there is no registry in Egypt, so we don't know how often it is. But there are polyps that genetically of origin, but they are not FAP. That's called something that new and methylated genes, and they usually happen in the large and small intestine, skin, ovary, and bladder. So again, in the family history, do not forget to ask family history of other types of cancer. Other factors that they are not theoretical, there is good evidence that they affect the risk of cancer. The night shift, and there are so many people in Egypt, their work is always at night. Ask about the job, ask about the social life, ask about exposure to sun. It showed, this study showed if you work 3 night shifts every month for 15 years, your colorectal cancer is increased by double, okay? It might be due to levels of melatonin, but researchers don't really know what's wrong and what's causing that. Other cancers, if they were present in the past, like testicular cancer, or radiation for prostate cancer and cervical cancer. And this is worth mentioning. Don't ever dismiss a woman in her 50s who had been treated with radiotherapy at her 20s from cervical cancer as having hemorrhoids. She would have rectal cancer until proved otherwise. It's extremely common after the large dose of radiotherapy used in the past for cervical cancer. And it also applies to people with prostate cancer, but at an older age. But women in particular with cervical cancer will be exposed to about 80 gray, the maximum dose of radiation we give in colorectal cancer as a neoadjuvant therapy or adjuvant therapy is 50 gray, which really fries the pelvis and fries the rectum. And imagine that multiplied by 2 or 1.4 or 1.5, and you will get how much is given in cervical and prostatic cancer. African Americans.
Dr. Majid, can you focus the slide more? It is hazy.
It's hazy.
Become hazy. Yeah. Okay.
It's not hazy on my screen. I don't know how to focus it. How do I do that? Okay. I hide my picture, you think? I don't know how to do that, to be honest. If I get rid of my camera, will that be better? Stop video. Can you see the screen?
Yes. Yes, very good.
It's better now. So it is the screen, the camera is doing that. So I hope you can hear me all right. Okay, so the African Americans, which us, okay, African Americans, not the Americans, they come from Africa, and so do we. Many of us, I think it's the consensus, 65% of Egyptians come from Nubia. So we do have these genes, so do not ignore that too. It doesn't matter if they are Americans, it is the genes that cause that. And the Jews, this, for example, I don't know if you see them in Egypt or not, the Ashkenazi are the Jews that, sorry, traditionally we'll think of them like that, people with beard and mustache, and sometimes they leave the sideburn of their hair long and curly, and they always wear hats. They're very clean, very educated, highly, extremely clever people. And they don't always look like that. Most of them look like this. Albert Einstein is one of them. And many of them have, in the past, they stayed in Egypt, and they are asked about grandparents and grandparents, because if they were of Eastern Jew heritage or ethnic group, they will also have risk of colorectal cancer. Diabetes type 2 it's double-fold. It's genetic, as well as traditionally type 2 diabetics are overweight. So this is an extremely important factor in the Middle East, extremely important in Egypt, because the risk of cancer is high. So if someone's diabetic with bleeding PR, please do not treat their hemorrhoids. Just investigate them further. Okay. So can we apply screening in Egypt? We can. Do you know when? When the 33 participants and the 100 who will watch this video take it upon their responsibility to spread the word and encourage people to have screening. Do not wait for the government to apply it. Do not wait for resources. It is not a massive undertaking, and it's not difficult to do. I think there is some urgent question. Okay. Okay. In the past, we used to do fecal occult blood. Fecal occult blood, I need to just mention one or two things about it. When I come to Egypt and people say to me, I have done, and even doctors say, FOB is negative. FOB that's done once is useless. FOB that's done without strict diet restriction before it is done is useless. FOB must be done 3 times on 3 consecutive days, not separate days. And there are a long list of diet and food will affect the result, and that's very important to be excluded. FOB can be positive if the dental hygiene is not great, and this is something very common. So FOB is not really a very good test. It is cheap, but it's not a very good test. So what we have replaced it in our screening program in England and the UK and in most states of America to FIT, fecal immunohistory test. Is not, this measures the genes of colorectal cancer and measures the biomarkers that's local to the cancer tissue. Very sensitive, very specific, and only needs to be done once. A lot more expensive than FOB, but it is a lot more useful. Some other tests are still experimental. They are present in the market, but without real approval, is stool DNA test. It measures the genetic material for cancer or polyps. In my opinion, screening by sigmoidoscopy for everyone above 40 is the easiest thing you can do, either flexible or rigid. You will find 75% of cancer if they are present. You will find 85% of polyps if they are present. So the cheapest way and the best for your practice is to train yourself and invest in flexible sigmoidoscopy in the clinic, in my opinion, in Egypt. Or if patient can afford it, FIT is the best. It can be prevented by screening, okay? It takes 10 to 15 years for a single cell to become even a polyp. So we have a lot of opportunity to prevent colorectal cancer. Teach your patients, teach your colleagues, teach your students to detect colorectal cancer early. How does it present if the patient's already developed it? You understand the percentage is very important. Most of them are asymptomatic. 50% of them are asymptomatic. So do not wait for it to happen and show its ugly face. Screening is important. Bleeding, it happens in 60%, and it can be any shape or form. Do not believe our traditional teaching that bleeding from rectal cancer or colorectal cancer is dark and mixed through the stool. Any bleeding above the age of 40 must be taken seriously. Any bleeding in a 16-year-old boy or a girl who lasts for more than 6 weeks must be investigated in Egypt. It is very common. And we believe in some unpublished data and research, we have been stopped to publishing this, is due to the CIMAD that was put in the soil in Egypt in the early 80s. And that's major cause of colorectal cancer in people of young age. Tenesmus is very common, but don't forget, when tenesmus happens, usually it's advanced, but it is a common symptom. Straining is different than tenesmus, because tenesmus, one would open the bowel with difficulty. Straining, one would not open the bowel, will just feel that they want to, but they don't. Change of bowel habits alternating between constipation and diarrhea is very important. So do not dismiss someone who has had bouts of diarrhea, and I think in Egypt they call it Ashour hadm. Very, very careful. Try to teach the patient. Don't take their word for granted. What's Ashour hadm? That the food is not digested. That's something I never understand. I really do not understand when they say that to me. I need someone, or some of you help me, how I interpret the symptom of الأكل بيقعد في المعدة، الأكل مش بيتهضم، عندي الدكتور قال لي عندي عسر هضم. I really do not understand it. What I understand is change of bowel habits. I used to open my bowel every morning after breakfast or as soon as I get up. And now for the last 4 weeks, I go 3 times in the morning and twice in the evening. Or, oh my gosh, I have been only going once a week. Pain is not that common, and it usually indicates advanced disease, but pelvic pain is 5%. Abdominal pain is 20%. However, it's very non-specific. Malaise happens when anemia happens, and that's usually with the right-sided colon cancer, which is only 5% of patients. Urinary symptoms happens not that frequent, but it's usually an advanced disease. Abdominal or pelvic mass or anal mass are also not common and also an advanced disease. So in Egypt, they might be common. I don't know the statistics for it, I'm afraid. There's no published data for it. Prolapse of mass per annum is common in elderly people. Emergency presentation still happens 28% in the UK after 30 years of screening program. So a third of patients still come as an emergency. How does it come as an emergency? By obstruction. You don't want to see this picture, but unfortunately it is very common. And people wait with their symptoms for years until they are obstructed, or because they're old, they are above 45 years of age, they should sit at home and stop complaining. So they will reach that stage of obstruction when they are 60, and it is rather unpleasant presentation. Or you don't forget the right side in a virgin abdomen will cause internal obstruction, and that's the old teaching of internal obstruction in a virgin abdomen is cancer until proved otherwise. It can bleed, extremely rare, and it usually happens in the background of IBD, ulcerative colitis, true ulcerative colitis or Crohn's, if there is a cancer developed with it. This is the only time that you will find real bleeding that presents as an emergency. Perforation is not uncommon, again, due to the same problem, and it usually happens subsequent to obstruction. But it can happen in the sigmoid colon if it has long-standing diverticular disease with cancer developing on top of it. How do we examine the patients? Don't forget your training and the undergraduate that you must examine the patient from head to toe, and you must not forget a PR examination. And I will add to this, for anyone above 40, do not forget to do sigmoidoscopy. Please, please do. If you have done that a lot, and if we call you a specialist in colorectal surgery, the accuracy of your rectal examination, as proved by research, will be about 80%. You will be better than any investigation done. In 27% of all colorectal cancer patients, you may feel a mass, you may see blood on the gloved finger, you might find prolapse, in otherwise no previous surgery or delivery or anything like that, especially in young people. And you use this examination for assessment because it has very important role in staging. There's Mason clinical staging is extremely important. And then the luminal examination, and most importantly, the luminal examination. And it is very important to do it. Do not assume that you saw piles outside that this patient needed admitting the same night for hemorrhagectomy. Please do not do that. How do we diagnose it? We will go through every test done, not because this is the right thing, but that's what I see in our practice. I've changed the order of these lists to include the things that are commonly done, while they are actually wrong. People diagnose cancer by measuring a whole list of tumor markers. This is really, really wrong. Not only in the evidence, not only in the practice, not only for the sake of the patients, but believe me, if you sit the Edinburgh exam and you are unlucky enough to come in front of me and you tell me that the first thing you thought of when you suspected colorectal cancer is CEA or CA125 or CA1999, you will mark 0 in that question. It is wrong. Please do not follow this practice. It doesn't mean anything. Complete blood count is important because if there is anemia that you need to, especially if it is iron deficiency anemia, meaning that low hematocrit, low hemoglobin concentration value, low hemoglobin capacity, that is indicative of iron deficiency. And iron deficiency need to be examined and investigated by upper and lower GI endoscopies, nothing else. Not ultrasound in the clinic, not ultrasound in the radiology center that you are friends with, not ultrasound in next door, not ultrasound at home. I have seen it all. It does happen. This is not the investigation of iron deficiency anemia. Iron deficiency anemia investigation is by upper and lower GI endoscopy. Liver enzymes will not mean much in the early detection of
Dr. Majid, صوت and presentation off. Dr. Majid. دكتور ماجد الصوت والبرزنتيشن راحوا دلوقتي. Close the connection and voice. Okay. With the voice. The presentation
okay.
come back.
Yeah,
okay.
Yeah. Am I all right now?
Okay, okay.
All right. Okay. Thank goodness. So it's not long left now. So let's say it again so everyone can hear it. It's colonoscopy and colonoscopy and colonoscopy. If you don't do flexible sigmoidoscopy in clinic or rigid sigmoidoscopy, send the patient for colonoscopy. But the biopsies, not only H&E, this is what you see. We all know that if you are unlucky enough or the patient is unlucky enough, you will see a tumor that big. But don't forget, there are some polyps that's so sessile in colonoscopy techniques. There are so many now, near focus and NI and zoom and studying of the crypt chains and crypt pattern is very important. Gastroenterologists can talk to you about this a lot more. But what I'm saying is colonic luminal examination and biopsies. And the biopsies, when you do flexible sigmoidoscopy or colonoscopy, do not forget to do a Jane maneuver, because low rectal cancer or anorectal cancer is usually hidden and you will not be able to see on the way out. Okay. Pit pattern chains are something to learn, and they're very important because they can raise the suspicion of cancer, especially rectal cancer. And when we come to the staging process and the biopsies, it's very important that you do not try to resect rectal polyps that are suspicious without previous staging investigation in the form of very high quality MRI or endorectal ultrasound or high resolution EUS. The specimens nowadays are not taken for histology and the pretty sight of histology under the microscope. They are also subjected to genetic testing, and this is something you have to think of in a young age. KRAS is very important because that will determine which line of chemotherapy will be taken, either preoperative or postoperative. And at that point, I will have to stop and pause and say, please, 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 please re-educate your colleagues. Chemotherapy for colon cancer, preoperative chemotherapy for colon cancer, is experimental. It doesn't have a proven track record of success. It is not indicated anywhere else in the world but in Egypt. I don't understand why, and it's a very high risk of perforation. It's toxic. It will kill the patient before the cancer kills them. It's useless preoperative. For rectal cancer, we have to be very selective, and if it is given, it has to be based on genetic testing. For example, in BRAF, there are so many of them of the chemotherapy and targeted therapy and immunotherapy are absolutely useless. In MSI, there is no rule for chemotherapy preoperative. In KRAS, there might be a role for rectal cancer, not for colon cancer. So 3 tests may be expensive, but as anything else in the world, if they are widely used, their price will come down. But will determine the right thing to do for the patients, not for our own benefits, not for the tradition, not for the culture that cancer means oncology and oncology means chemotherapy or whatever it is. In America, there are so many people who would laugh about it and say, what is the indication of chemotherapy? The indication is you have pulse. If you have pulse, you will have chemotherapy. Oh, when do you stop the chemotherapy? Oh, when you die. We are not going to stop it. This practice comes from America, and it is, in my opinion, and many others, it's criminal. Genetic test is very important on the specimen taken from colonoscopy. Perimeninema has a role. It hasn't died, but only if there is no obstruction, only if it is done properly by double contrast, and it is used for detecting synchronous tumor. Do not forget some rule for people who haven't heard it before. In this area here, in the rectum and the rectosigmoid, if there is a polyp more than 2 centimeters in diameter, 9% there will be cancer on the right side. 14% there will be other polyps in anywhere in the colon. So do not forget these facts and study the other side, either barbarian enema, which is cheap, or double contrast and negative contrast CT scan. Virtual colonography is started to appear more in Egypt, and I started to see a lot of people coming with CTs saying, I've had CT colonography. Just one slide, and I would leave it at that. That is how the virtual colonoscopy looks like. It doesn't look like a perimeninema. It doesn't look like the previous slide of black and white picture. It is as if you have seen the colon by colonoscope. If your radiology center does not provide these pictures for you, it means that you do not have the software. They have the CT machine, they have applied the technique, but they don't have the software that produce and process the real virtual colonography pictures. I will let you in a secret. This software is expensive, very expensive, sometimes is as expensive as 50% of the machine itself. Every study needs 2 hours analysis by the machine, by the best machine in the world. No radiology center wants to spend 2 hours analyzing data. They want 100 patients to come through with better studies and better income. As long as we treat our patients in the private sector, as long as we are not going to investigate them properly. How do you deal with that? Don't send them for colonoscopy, send them for colonoscopy. It's a lot better for the patients. Okay? That is how it looks with virtual colonography. If you tell me that this is available in Egypt, I would love to see which center, because I will work with them. Do not do CT scan for diagnosis. It doesn't help. The false negative results are very high, up to 32%. Do not use MRI to diagnose cancer. Use it for staging. Do not ever use PET scan. Leave the PET scan to the oncologist to follow up their treatment. It's useless for diagnosing suspect colorectal cancer, because if there is rectal cancer and the dose is just not right of the sugar-containing contrast, it will be absorbed by other organs before the cancer and you'll miss it. If the cancer is present and it will diagnose, you will find scar tissue in the liver that will have high uptake. You will think it's cancer, metastasis, or you will miss small cancer in the liver. So the PET scan, while the primary tumor is present, because it will be avid, it will take all the sugar. It will not leave enough sugar for the metastasis somewhere to take. And what is the point of having a PET scan that doesn't tell you more than a blob of light on a film? It doesn't tell you anything else. It doesn't tell you about the stage of the lymph nodes if they are small. It doesn't tell you about the T stage because it doesn't give you the depth of the tumor. In my opinion, it's money spinning practice. Is not evidence-based. It is not based on any benefit to the patients, except that patients, unfortunately, will be convinced to go and have chemotherapy, whatever the outcome is. I'm sorry to be brutal and honest, but that's what it is. I have seen in Egypt so many patients, and now I have a clinic online, so many patients, they tell me, the doctor did ultrasound and he told me, I have inflammation of the bowel. Or they tell me, you don't have cancer of the bowel. So I looked in the literature and I asked my friends, I asked my colleagues who are radiologists here in some parts of Europe and in America, and not a single person came to me and say, the ultrasound is useful, the abdominal ultrasound is useful in diagnosis of colorectal cancer. It is absolutely useless. Patients believe us. When we say anything, they will believe us. Please refrain from this practice. It doesn't matter if the patient will trust you because you use ultrasound in a clinic. You have to deal with Allah at the end of the day. And dishonesty, it doesn't get us anywhere. It really doesn't. Again, apologies for being brutally honest. Other tumor markers for diagnosis are useless. They are not related to colorectal cancer, but I have seen them all. I see patients coming with a list of investigations that they have really paid a lot for, and now they can't afford the treatment. They can't afford paying for it because they have exhausted their resources and the doctor's resources in useless investigations. So this list, please put it in mind, not to be used. Some of it will be used for staging, and we'll talk about this in the next webinar, but not for diagnosis. Okay, I will leave the staging now because it will be discussed in the next webinar, and I'm happy to take any pictures. Where is my screen? And don't leave. Oh gosh, where's the screen? I will stop the recording now. I would leave it to the discussion. I'm sorry, I can't find how to do the screen. Ah, here it is. Okay. Well, any questions are more than welcome. So I don't know if you allow people to unmute themselves and appear on the camera. I'll be happy to answer anyone personally.
Okay, so we'll start the question. أي أسئلة أو حد أي كومنت أو أي أسئلة؟
Great, so everything is clear.
Ahmad?
أيوة اتفضل.
Is there any relation between previous cholecystectomy and colon cancer?
Not proven by research, no. I know where this came from. It was a paper from Romania. Someone said, but actually the numbers were very small and the paper was not really of any quality. Anecdotally, I do not know of any relation between cholecystectomy and colon cancer. Do you know anything different?
No.
Okay. No, I think we can agree that there isn't relation between both.
Thank you.
Thank you for the question. Thank you very much.
More questions?
Dr. Habib?
تفضل دكتور حبيب.
You are muted, Dr. Habib. The microphone.
You can unmute دكتور حبيب. تفضل دكتور حبيب. تفضل دكتور حبيب.
Would you prefer writing?
كان الدكتور أيمن مش موجود، كان رافع إيده.
Dr. Habib,
أيوة مع حضرتك.
unfortunately, is not connected to the mic.
تمام. هو حضرتك على بال ما يعني أي حد يكتب questions أو كده يعني حضرتك أشرت ل very alarming signs and symptoms that we should be considered in any patient presented with hemorrhoids like tenesmus, and so on. And also the importance of CT and diagnosis. I think we'll give it more than actual.
Yeah, that's right. It's overused. Unfortunately, in the Middle East and Egypt, it's really overused as the first line of investigation. It's extremely useful and mandatory for staging, but not for diagnosis. Let alone because the quality of CT scan is not the same in every center. So the people will be missed from, and it's false reassurance to the patients and who will not seek further advice, who will not come back because the CT scan told them that they are okay. So there is serious issue with it.
Okay. أيوة اتفضل.
في الألسرتيف كولايتس. السلام عليكم.
اتفضل يا دكتور محمد.
In case of ulcerative colitis,
Yes.
site of develop of colorectal cancer. يعني الميكوزا كلها بتبقى ulcerative. الكانسر بيطلع منين؟
And if it happens in one place and not only cancer, if dysplasia is severe in any place you've taken biopsies from, even if it looks just ulcerative colitis, it means it is multifocal cancer. It's everywhere but submucosa. Because the mucosa, it's actually very easy to understand. The colorectal cancer starts in the mucosa, except in ulcerative colitis. It starts in the submucosa because the mucosa doesn't exist. It's shedded.
Start in submucosa.
And the submucosal start of glands, because it doesn't start from the goblet cells exactly, it starts from the blood vessels. And if it does start from the blood vessels, it will spread in the submucosa like wildfire. Hence, the treatment of colorectal cancer is always pan-proctocolectomy, and preferably not a PAP.
After colectomy, after total proctocolectomy, if there is any risk of cancer after that?
Not of colorectal, because the whole colon and rectum are removed. So there isn't. If you are talking about pouch surgery, restorative proctocolectomy, I published papers from 94 until 2014 about this subject, and there are so many case reports. In 1996, there were 17 cases reported of cancer in a pouch. And in 2016, there was good systemic review indicating when cancer in the pouch is done when pouch is done for indeterminate colitis, or in some cases of Crohn's colitis, when surgeons think that it can be done, the cancer is nearly 60% in the pouch. So yes, after restorative proctocolectomy, there is good incidence of pouch cancer. I reported the case number 7 in the world in 1994. And after that, many more cases were discovered, because so many, the pouch for indeterminate colitis was popular until early 2000s. So yes, there are cases of pouch cancer. If we do not do pouch, the cancer is nearly nil.
Dr. Majid, you insisted about eosinophilic colitis. And
Yes.
actually, I said to colonoscopist that where there is complaint of tenesmus and mucus, I said to him, you should take random biopsies for such cases. Do you accept such practice to do routine biopsy, even the apparent normal mucosa?
Yes.
Yes.
Yes. There is a question here. What's the best lab test for early detection, age, and frequency? The question is about the best lab test. I would say FIT. Okay, fecal immunochemistry, immunology test. Okay, this is the best lab test for early detection, which is used for screening.
Okay, any question more?
Thank you very much. It was really a pleasure to chat to you all, and hopefully in the channel or the Facebook or YouTube, you can put more questions and I will be very happy to answer them. One thing I wanted to, I've designed a service for young surgeons in Egypt. If you have a difficult case you want to discuss, try to find me on Facebook or any other social media. And we can discuss not only in Zoom, but I have a private medical platform which is confidential and private, and we can store medical data on it officially without getting in trouble, because it's very important here in England about patient confidentiality. So if you have a difficult case, we can chat it by video. But I would request from you, please, if you have any investigation, store them on a CD or in your computer, because I would like to see them with you, share the screen during the consultation. And if the patient is present and you want me to help you in discussing any treatment plan with them, for Egyptian surgeons, I would be very happy to provide that service, okay?
Okay, Dr.
There is another question, I think.
Okay. Not apparent for me.
Okay, I don't know. Someone who's admitted, I don't know who. Okay. All right.
Okay. At the end, we are very okay. Any question more? Okay, at the end of this illustrative, very interesting question, we are very thankful, Dr. Majid, and we hope to meet you and more.
Inshallah, promise, inshallah, we'll meet again.
وكل سنة وحضرتك طيب وجزاكم
وانتم
الله خير.
طيبين.
ونشكر حضرتك كتير جدا ونشكر السادة الحضور وجزاكم الله خير. وأول محاضرة ما إن شاء الله هننزلها على طول على اليوتيوب. شكرا دكتور.
ان شاء الله
جزاكم الله
حبيبي،
خير.
مع السلامه.
الله يسلمك.